Hello, I'm Banu Arun. On behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Tackling Barriers to Genomic and Biomarker Testing in Precision Cancer Medicine, integrating the latest evidence into practice for community oncology clinicians. In this episode, we will be discussing accessibility, availability of genetic counseling. Today's program is supported by an educational grant from Merck Sharp and Dome LLC, a subsidiary of Merck & Co. Inc. I am again Banu Arun, professor of the Department of Breast Medical Oncology, co-medical director for clinical cancer genetics, and section chief of breast genetics prevention and screening at the University of Texas MD Anderson Cancer Center. Joining me today is Dr. Eugenia Ioffe, associate professor at the Loma Linda University School of Medicine, chief division of gynecology oncology, Loma Linda University Health in California. Welcome, Dr. Ioffe.
Thank you, Dr. Arun. Pleasure to join you. Thanks so much.
Eugenia, let's start by reviewing our learning objectives for today's session. After participating in today's activity, participants should be better able to employ strategies to provide genetic counseling for patients with cancer. If we need to acknowledge the problem, the need for genetic testing is expanding across oncology, but somewhere around 80% of patients who need genetic testing and counseling are not receiving it. Dr. Ioffe, a recent study indicated that more patients with breast and ovarian cancers are receiving multi-gene panel testing rather than just BRCA1 and 2. But the portion of patients who should have received genetic counseling has not substantially increased. It's still around 25 to 35% range. What do you make out of all of this?
Yeah, thank you, Dr. Arun. You know, it was a fairly recent study published in 2021, and I found the data quite compelling, coming from a large database, Sierra database. It showed, I think, what we've seen in clinical practice, that the multi-gene panels have become quite ubiquitous, but unfortunately, these graphs show that very nicely that the actual rate of testing is barely moving. The lines, almost look plateaued. Would say possibly a little bit better in ovarian cancer, but I think, it highlights what we're going to discuss today in our program is, lack of availability of genetic counselors, possibly, lack of conversation and lack of, once the orders are placed, lack of implementation for different reasons. So I think these graphs are very telling. They highlight what we see in practice, and unfortunately, quite disappointing.
Yeah, I think, the literature really has a number of studies giving us percentages of the low testing rate when it's indicated, like you said. But why is genetic testing really important? Does it play a role in treatment, for example, of breast and ovarian cancer patients?
So we know, going back 15 to 18 years, I would say there's a number of studies looking at the percentage of patients that actually carry germline mutations leading to the breast and ovarian cancers. And I generally quote, with patients and colleagues that, anywhere from 10 to 15% of ovarian cancers are due to the germline, so inherited mutations in the Fanconi anemia pathway genes. So of course, BRCA1 and 2 being the most common, but also, that's highlighted with the multi-gene testing mutations in genes such as BRIP1, RAD51C and D, PALB2, and also the Lynch syndrome, as I would say colloquially, genes, the mismatch repair genes. So 20% of ovarian cancers, that's 1 in 5, that's quite important. So while we know that universal genetic counseling and testing is not recommended for all women, it's very simple really with ovarian cancer. If you have a diagnosis of epithelial ovarian cancer, then it's an automatic recommendation for genetic testing. but, only, maybe 30, 35, 40% gets done. Also, there are various reasons, but, some we've seen disparities by race and socioeconomic status in testing. So that can also hinder uptake and make the problem more complex. So, there's been a number of studies that show that possibly white Caucasian patients have the highest um, conversion rate actually proceeding with testing, and with Black and Hispanic patients usually being the lowest. But this could potentially also be linked to socioeconomic barriers and kind of be confounded with that.
And again, the implications are major, right, for treatments. So what can you tell us about that?
So I'd like to just look at this simple schematic that we have on slide 10 regarding treatment of ovarian cancer. So we know that treatment of ovarian cancer, the mainstay is still surgery, of course, with our platinum-based and doublet therapy, platinum taxane therapy, and sometimes the use of bevacizumab, as we've seen in some large phase 3 studies. And then, so what we've arrived at fairly recently in the last decade or so is the maintenance therapy. So once the first line is done and there is a response, we have added maintenance therapy, and often with PARP inhibitors. And the genetic testing, and by genetic testing, I mean germline testing of the mutations that the patient carries, but also the somatic testing of the tumor helps us triage the degree of benefit to help us counsel the patient regarding the degree of benefit that the patient would derive from maintenance therapy, to help us decide whether maintenance therapy would be appropriate with PARP inhibitors, or surveillance may be almost just as good. So we've definitely, of course, germline testing is paramount for the patients in terms of their risk of hereditary cancer syndromes and their next of kin testing. But patients with germline and somatic mutations and PRCA genes also garner benefit from the maintenance therapy. So, so it's the benefit is really multifactorial.
Right. So for a practicing physician, how do we search for this? There are NCCN guidelines. Can you help us going through them a little bit?
Oh, yeah, I'd love to. And of course, I think the beauty of it that the NCCN guidelines get updated so much. So, as new large studies come out. So I do think it's important to check them often. So just as a refresher, the maintenance therapy is defined, as we saw on last slide, as something that is started after remission is achieved after both chemotherapy and surgery, given either surgery first, then chemotherapy, or chemotherapy and then surgery. And the main benefits in ovarian cancer thus far have been in progression-free survival. That has served as the primary endpoint in a lot of the studies. So, for example, these NCCN guidelines version 1.2023 for post-primary treatment of stage 2, 3, and 4 ovarian cancer to see if there's a response. And then there's a triage in terms of whether the patient received bevacizumab, the biologic, along with the platinum taxane backbone. And then it goes directly into the BRCA testing for patients who have the mutation. It's strongly recommended, as you can see, sort of top middle panel, that we would consider olaparib and niraparib. For patients who are wild type, both in the germline and somatic, observation may be appropriate because the degree of benefit in terms of the progression-free survival is not as great. But there was a study, phase 3 study, that showing that there is a benefit even for patients who do not carry the BRCA1 and 2 mutation, and the tumors are homologous recombination proficient, there's still a several month benefit in terms of progression-free survival. That's why niraparib, one of the PARP inhibitors, is also appropriate. So, and the NCCN guidelines currently ask that if the patient received bevacizumab, but the patient is HR proficient or and germline wild type, we just stick with bevacizumab. But you could combine both. So as you can see, this is, a big fork in the road, and we want to know this, rather early in the game by the time that the surgery and the primary chemotherapy is done. So it's very important that, we assess the germline and somatic status, and we do that pretty much right away upon presentation to treatment. I think we also wanted to review some of these Paramount studies. For example, the SOLO-1 trial with olaparib. There were a lot of prelim studies, but this was a large phase 3, which really showed amazing benefit. The patients enrolled all had advanced ovarian cancer, stage 3 or 4, and the histologies were serous and endometrioid. The patients, the inclusion criteria was that the patients had an attempted surgery and chemotherapy, and they had good performance status, and then achieved a clinical partial or complete response. And then there are randomized 2-to-1 in favor of olaparib, and there's some curves here, and there's also some other curves in the paper showing that there was a 70% decrease in the risk of progression or death in favor of the population receiving olaparib. So that's hazard ratio of 0.3, very impressive as far as studies go, because personally I'm happy with 0.6, even, maybe going towards 0.7, but 0.3 was quite impressive. 70% risk reduction in risk of death or progression at 36 months, at 3 years. And then there was a 7-year follow-up, which showed that there may be a benefit in terms of overall survival, which was very interesting, as the large PARP inhibitor trials so far have been geared at showing progression-free benefits. So, so for patients with germline and somatic mutations in BRCA, we are very keen on using PARP inhibitors in maintenance setting. So,
right. It's really interesting times, right? That genetic risk assessment really helps with the management of patients. And we see very similar trends now in breast cancer also, right? There are 2 prospective single agent studies with olaparib and talazoparib showing a improved progression-free survival in metastatic breast cancer, but also the Olympia A study showing for the first time improvement in overall survival in the adjuvant setting by about 30%. And the NCCN guidelines have captured that as well. Do you want to say a few things about the testing criteria in NCCN that relates to breast, and maybe then we can go into pancreas and prostate as well?
Yeah, also to point out, I thought it was very interesting a few years ago that the actual hereditary cancer syndrome got renamed to include the pancreas, from hereditary breast ovarian cancer to hereditary breast ovarian breast and pancreatic cancer syndrome. So, of course, we still think for young women for breast, and this is your area, so please correct me if I'm not looking at this as I should, but, anybody with young age, less than 50, and a diagnosis warrants genetic testing. Anybody with Ashkenazi Jewish ancestry, because of the enrichment in the population of germline mutations of BRCA, et cetera, warrants testing. And anybody with triple negative breast cancer, because of the association with germline mutations being a telltale factor. Of course, multiple cancers, something we see also with hereditary cancer syndromes, and then also lobular breast cancer with personal or family history of gastric cancer because of the association with certain genes. Otherwise, if we're just going by family history alone, you don't have to, I love how the guidelines show that, it could be based on personal history, but then also the juxtaposing with family history, in the preventative setting. So anybody with close relative of male breast cancer, and of course, any, personal history of male breast cancer would do as well. And then anybody with a close relative, I believe a first or second generation, because that's how it is for ovary, and then with ovarian cancer, pancreatic, or high risk pancreatic cancer, and then more than 3 total diagnoses of breast cancer in a patient or close relative, or more than 2 close blood relatives with breast or pancreas. I'm sorry, a breast or prostate of any grade. Also, going back to age 60, female diagnosed with breast cancer at age 60 with no close relative of breast, ovarian, or pancreatic is a low probability because, going back to the fact that breast cancer is so common. So I think, they highlight that there's a less than 2.5% chance if it's a woman with no close relatives and more in age 60. And then for ovary, as I was saying, it's really quite simple. Anybody with epithelial ovarian cancer, even mucinous type, we used to, kind of double guess that one. But, anybody with epithelial ovarian cancer warrants genetic testing, at least germline genetic testing. And then by family history, an affected individual of a first or second degree blood relative with epithelial ovarian cancer, so parents, siblings, or grandparents at any age. And then if you use any of the computational models, and the probability is more than 5%, but that of course is more advanced and probably takes, a genetic counselor or a breast oncologist to calculate that. With pancreas, anybody with exocrine pancreatic cancer or first degree relative of an individual with exocrine pancreatic cancer should be tested. So for prostate, anybody with Ashkenazi Jewish ancestry or based on tumor characteristics, prostate cancer is metastatic or based by high or very high risk group histology should be tested. And then the same for the first degree relative meeting of the criteria above. So really it's, kind of, I guess to summarize, you either meet these criteria outlined or you have a first degree relative that did, and then hopefully, the testing can get to the individual before they get the cancer. And, that would be the ultimate success. Of course, this all sounds great, getting to down to the bottom of this puzzle and doing the germline testing before the individuals get the cancer. But then, we get into the practical issues, and there's probably some variability how things are with access to genetic counselors in the community and the large academic centers. But even, I think, in larger academic centers, there might still be a backlog. I know we have quite a long backlog of getting to the genetic counselor. And that was sort of the conventional way that the counseling and testing was done, is that, physician makes the referral, the patient sees the genetic counselor, and there's extensive pedigree, the family history is gathered, there's pre and post counseling, discussing all the risks and benefits, the possible trauma and the implications of the information. Then the test is done. And then, but
what happens when we don't have enough genetic counselors, right? When we cannot do the traditional. So how can we approach it then?
Well, luckily, I think luckily, since there are so few, some states allow for direct testing, almost direct to consumer testing, for example, for an advanced for a physician with advanced knowledge of cancer genetics. So, as an oncologist, you probably had quite a few rotations where you interfaced with genetic counselors or studied cancer genetics to pass your boards. So you could just go ahead and order the testing, either, from laboratories, conventional laboratories like Quest or, LabCorp, and then, or, these companies, larger companies. So oftentimes we can just, you have the patient, you have the captive audience, and you don't want to take the chance that, the referral won't go through, or, there's a backlog. So you can just go ahead, talk to the patient about the risks and benefits and do that. You can also take advantage of some of the telehealth, which of course has become more abundant and helps cut down the wait. So, some telehealth appointments, but then, your disadvantage is that it's not in person and that blood can't be drawn right then and there. Blood is saliva, the biospecimen can't be collected right then and there. But, there are some ways. I think there's a little bit of an improvement.
Yeah, I mean, I think we have to really be innovative, and leverage technologies. I think when telemedicine or telegenetics is used, I think, that can be done by the provider or with a genetic counselor. So they, get to talk to a genetic counselor. The way we are overcoming the blood draw barrier is we can actually send the spit kits to the patients and, with saliva testing, so they can then get the testing. I think that is one way we were able to service a lot of patients. The other, I think, I love when you said, providers, especially for the low-hanging fruits where the guidelines are very straightforward, all high-grade ovarian cancer patients or all metastatic breast cancer patients, maybe do the provider order testing, and then only the positive results or the uninformative negatives, VUSs, where there needs to be a discussion. Those patients could be perhaps called by the genetic counselor. That would, save a lot of time and effort as well, but we would get a good service to the patient.
Yeah, I do think, a lot of providers kind of have independently arrived at that heuristic that, not to underplay the importance of negative, but, negative is negative. And while we want to make sure that the implications of that are understood, but I think that's a little easier to navigate and perhaps, doesn't necessarily necessitate a visit to genetic counselor, whether, I think any positive result, warrants a pause. So, but at the same time allows to move along and do this high volume testing that, for example, as a oncologist or GYN oncologist, if you see, a lot of gynecologic cancers, so many of your patients are going to need testing, and then, you got to move forward. You got to get it done somehow. So before the maintenance time comes. So
yeah. I think it's important for all healthcare providers to recognize that the patient is eligible and should, be referred or have the testing. For breast, for example, we work in a multidisciplinary fashion. So some patients are seen by medical oncologists, then we go ahead and start the genetic counseling and testing discussion. And many times for early diagnosis or image guided diagnoses, it's the surgeons who actually send the patient. And sometimes it's, our advanced nurse practitioners who sees patients. So it looks like it's really a team effort, and anyone who is a part of the multidisciplinary team should think about it and should be able to refer the patient. And I'm sure it's the same with gynecologic oncology as well.
And of course, with the entry of advanced practice providers into the oncologic world, we definitely they've become integral part of that as well. Thank you for pointing that out. I failed to mention, but I think, definitely huge help, and also facilitating the testing and, going through the pedigrees with the patient and explaining the implications. And, sometimes there are videos that can be shown that, come through from the company, even, we have a nurse practitioner who has a special interest in testing, and she's been doing a lot of those appointments, but shows some videos and shares some information. And while not a certified genetic counselor, can has a wealth of information that can definitely provide an adequate, I would say, service in terms of that.
Right. So thank you for all of this information. I think if we need to wrap this up, I think what we went through today is that, we are in agreement. There's suboptimal genetic testing in patients with cancer based on studies. Less than 20% of individuals who would be eligible for genetic testing with a history of breast, ovarian, or some GI cancers are actually referred and undergo testing. There are universal testing guidelines for patients with all metastatic breast cancer patients, all epithelial, high-grade serous ovarian cancer patients that should be ideally referred. There are also guidelines, you reviewed them very nicely, for pancreas, prostate, and others. And we all know that there are insufficient numbers of board-certified genetic counselors, particularly in the community settings. And we also reviewed that we need to be open to employ innovative strategies, leveraging technology and a multidisciplinary approach to be able to provide genetic services to our patients. Well, I want to thank you very much, Dr. Ayofi, for this very interesting and important topic and discussion. Let me close out this program with some SMART goals, which are smart, measurable, attainable, relevant, and timely. And these are: use guideline definitions for patients with a high risk of harboring cancer susceptibility genes and refer these patients for genetic counseling. Follow up with your patients who are recommended to have genetic counseling and address any barriers that reduce adherence, and encourage your clinic administration to investigate the breadth of innovative strategies to provide genetic counseling for all patients. Again, thank you, Dr. Ayofi, for your discussion, and thank you to our audience for joining us today.
Thank you, Dr. Arun. Really enjoyed being here, and very, very interesting discussion and very important points, and looking forward to see how this evolves. Thank you so much.